Hello, Ava. I apologize. I was running from another meeting, and hi to everybody who's here. So I'm good. I see it's 4 o'clock, so I'm good to get started whenever it works for you.
Yeah, no problem. I'll flip to the next slide.
Okay. Hi, everybody. Appreciate everybody joining. Hi, Tamika. Thank you for turning on your camera. Folks certainly don't have to turn on their cameras, but if you are able to, that's lovely. Hi, Catherine. I did just relocate myself from the dark hovel that is my office to a sunny window so I could capture the last bits of daylight. So I apologize in advance if Amazon brings me any goodies and my dogs get excited. So I'm Eva Freed. I'm the clinical director for midwifery and women's health. And I usually do kind of a bonkers thing and try to keep up with the chat while I'm also guiding the meeting. So I rely on my colleagues to advance the slides and answer some of the questions. So let's have them all introduce themselves next, if you don't mind. Folks who are on from Frontier, if you want to, I'll say names just so we don't talk over each other. But Sarah, I see you. Do you want to say anything?
Hi, yes, I can. So my name's Sarah Johansson. I'm one of the new clinical advisors. So our department is the Clinical Outreach and Placement Department. We work with you all one-on-one to kind of develop a plan for clinicals. We assist with the clinical site search process, all that fun stuff. And Ava, if you don't mind, I'm going to go ahead and put our group email or general email
Yeah.
in the chat just in case they need us to answer any questions.
That'd be
Thank
great.
you.
Thank you. And Ava, I see you next.
Hi, everyone. My name's Ava Bumbu, and I work on the marketing team.
Thanks, Ava. And I saw Quincy next. And after Quincy, I'm not sure if somebody's here from admissions. That would be super helpful if somebody is.
Hi, I'm Quincy. I'm in marketing as well, and I do a lot of strategic communication and public relations here. And I think Tamika is on the call from admissions. So,
Awesome. Okay. Yep. I saw you there, Tamika, and then the order rearranged. Thank you.
Yes, I'm Tamika Bradford. I'm an admissions counselor working in admissions.
And did I miss anybody who's on the call that's at FNU? Okay. So, folks that are here to learn more about the program, please do not be shy to go ahead and put something in the chat. I prefer to be able to answer a question when it comes up. I think it's infinitely more interesting for all of you than to just look at slides. So, I will not feel interrupted. And it's not possible for me to see you and see all of you. I can see a few of you and share the slides at the same time. So if you were trying to be nice and raise your hand, I wouldn't see that. So please go ahead and put any questions in the chat as we go. Next slide, please. Okay. So I will not read the mission to you because you can read it, but I will share what you're seeing here. Thank goodness we're not masking on campus anymore. This looks like it was a transition time where some people were masking and some were not. You're welcome to mask on campus if that's comfortable for you. This is our Bell Pavilion, and we have a lot of traditions at Frontier. One of them is ringing the bell when you leave your clinical training. And that is a vestige of when the nurses at the Frontier Nursing Service were ringing the bell and going out into the community to give aid where it was needed. So you're seeing some of that formation of community. Another thing that's really important to us is creating a scaffolding of relationships throughout your time at Frontier so that even though most of the work happens from your home community, that you are connected to people, faculty, staff, and other students that are also part of the Frontier community. Next slide, please. Okay, so as I started to allude to about scaffolding your social experience, everything that we do is grounded in our what we call the culture of caring. Um, and so that is a structure around communication and relationship building that we think sets the foundation for lifelong learning. Your own community is your classroom. The majority, you will come to campus twice, which we'll talk more about. The majority of your learning when you're in the didactic or textbook part of the program will happen between you and your laptop, wherever you need it to happen, at your kid's soccer game, at the library, at home. And then you will work with a preceptor in your own community. Ideally, some people choose to travel, or find that they need to travel if they're from a especially remote community, but you'll work with a preceptor for your clinical learning. Jennifer, great question. I'll get to that in just a second. Thank you for that. And then, oh, I went out of order. You'll come to beautiful, you say that, Versailles, Kentucky, for your orientation and skills intensive. So the answer to Jennifer's question about whether the program is asynchronous is a little bit complex. So it's asynchronous in the sense that it's not like every Thursday at 4 o'clock you have to be online. Like I've taught in online programs that were like that, like, oh, this class meets Tuesday at 4 and this class meets Thursday at 10 a.m. It doesn't meet like that. But almost all of your didactic or textbook classes will have live sessions so that there is room for group discussion or a simulation experience. But the way that those are scheduled, because we know we have folks at military bases, even outside of the US, during the didactic portion of their program. And we know that lots of nurses work night shift. So people are awake and functioning at all different times a day. So what happens is those courses that do have some synchronous component, the course coordinator puts out a calendar, typically the first day of the term, and students can sign up for slots that work for them. And some of those are going to be daytime, evenings, weekends. And there's usually just a handful of them in each course. And that is nothing that I've never, ever heard once that was a concern for anybody. It's not like all the good slots are taken right away or anything like that. It's very doable. The clinical learning is in person, but it's in your home community. And then again, there's the 2 trips to campus. So most of the didactic learning is asynchronous. Next slide, please. So I always think this is silly when you add up people's experience, you know? And so I guess that's coming on the next slide where they added up all the faculty experience. It's sort of funny. We have 1,000,000 years of experience. But the university has a very long history in distance education. It's not something that we just started doing because it's trendy. Distance education started many, many decades ago at Frontier with literally mailing paper packets. So this idea that folks were needed to grow from nurses into advanced practice nurses in their home community is not a new one. And it's something that we have a lot of experience in. And you can see that if we had 2,500 students every year, we would have a lot more than 10,000 graduates, but our program has grown exponentially in recent years. So there were many, many years when we had a small number of graduates, and now we have this relatively enormous enrollment on an ongoing basis. Next slide, please. Lots of fancy things that say that we're good at what we do, but I'll tell you more about that in detail as you continue on with us here this evening. Next slide, please. Okay, so again, the structure of student support throughout the university. So the team that I lead is called Regional Clinical Faculty, specifically for nurse midwifery and women's health NP students. Those are doctorally prepared faculty that reside in almost every state in the US. So we don't all live in Kentucky. We live all over the country because our students are all over the country. And we develop relationships with preceptors all over the country, and we understand sort of the culture of care that's happening in different geographic areas. So again, we're positioned similarly geographically to our student body. And most students are assigned the same regional clinical faculty person for the entirety of their program. So you'll have different faculty in different didactic courses. Your regional clinical faculty is your course faculty for the entire clinical portion of your program and will provide some guidance and mentoring during the didactic portion of your program as well. We also have a team of academic advisors and a team of clinical advisors who help you put together your clinical plan, so the plan for where you'll be doing the clinical part of your learning. There are online mentoring groups and student interest groups that you are welcome to engage in, but not required. We offer financial aid and scholarships. Our library is amazing. The librarians get back to you like almost before you hit send. It's really bananas. Like I've had to schedule send my emails to them because I'm like, I literally don't need you to find this for me at 11 o'clock at night. But even if I say it's not urgent, they are like right on it, monitoring our library needs. And then we have an Office of Diversity, Equity, Inclusion that I spoke to the student interest groups, but also hosts an annual Diversity Impact Conference that I think is now available virtually and in person on campus. Next slide, please. So scholarships are available during various terms. One thing to know, if you're eligible for federal financial aid, that is a whole separate issue. But in terms of our internal scholarships, you do have to earn, excuse me, a minimum of 24 credit hours at the university before you're eligible for scholarships. And you need to have the minimum GPA that you can see here. And that is because obviously we want to invest in people who are invested in their own success and have shown a commitment to program completion at the university. Next slide, please. Okay, so the Office of Clinical Outreach and Placement is the folks who earlier I referred to as clinical advisors. This is probably like more detail than you need at this moment, but a lot of prospective students are worried about how they're going to put together their clinical plan. Like, do you just tell me where to go? What if it's too far from home? All that kind of stuff. So we go ahead and speak to that when you're kind of thinking about where you might want to go to school. So this is an office that works directly with you from the time you come to Frontier Bound, which is your first trip to campus, until you're at your clinical site about halfway through your program, half to 2/3 of the way through your program. And what they do is help you identify sites that are in your home community or as close as possible as we can get to you that help meet your learning needs and will help you to be successful on boards and as a new clinician. And they will, I say we, but it's not me that does it. So let me give credit where due. I mean, they will literally help you with the technology of like, where do I hit submit? If that part is what's holding you up, as well as thinking about, how do I tell a potential preceptor exactly what I need? What makes me kind of stand out from the crowd? We also have an enormous resource that we call the community map that's available once students are enrolled. That's a jumping off point to literally thousands of sites and preceptors that have partnered with us in the past. Next slide, please. Okay, so who are some of these people? Eileen Thrower is the department chair for the Department of Midwifery and Women's Health Nurse Practitioners. I'm the clinical director. Your didactic courses each have a course coordinator, and there will be multiple course faculty in each of those courses. Those folks you usually will just see in one course. They might be in your antepartum course, for example, and then you'll have new faculty when you move to the next course. Whereas your regional clinical faculty are in an advisory or mentoring role for the duration of your program, and very specifically throughout all your clinical courses. They are your number one faculty that does not change throughout the clinical portion of your program. I spoke a bit already to your academic advisor, clinical advisor, and you'll also have a financial aid officer and the credentialing coordinator. Credentialing is the nuts and bolts of making sure that you're approved to be at a clinical site. Like, do you have your fingerprints done? Do you have access to the electronic health record? Do you have the right badge? Are the right dates on your contract and all that kind of stuff? So we've got a whole team of folks, and this is just, I don't know, they probably used AI to pull everybody on there besides Dr. Thrower and me, because they're all wonderful. And I don't know how we chose just that small handful of people, but it takes a lot more than that small handful of people to support our students. And we'll all know you as an individual. You're not, just a number, even though we have 2,500 actively enrolled students. Next slide, please. Okay, so yeah, just might as well tell you from the outset. I lived experience going to graduate school many times myself. I think I've been to graduate school at least three times. I am a women's health NP and a nurse midwife, and I have a doctoral degree. So I guess that's 3 times. And I just thought, yep, I'm going to do this. Off I go. Never had a ponytail, but off I go with my little ponytail on my little bike to the finish line. And it looked a lot more like the one below. So, we know that life throws all those curves, and that's why we've built this social scaffold to support your success, because once we offer you admission, we're invested in your success. Next slide, please. Okay, so degree options. I think everybody here is thinking about the master's degree, but because a lot of programs are a BSN to DNP, it is important to say that we offer those separately. So what you would be looking at is a master's degree option. that you could come back after your master's and do a postgraduate certificate. Say you wanted to do midwifery and psych mental health. You'd have to do one of those things first and then come get the other one as a postgraduate certificate. Likewise with the DNP. The DNP is a separate enrollment and you can only enroll in one program at a time. So if your hope is to eventually get the DNP, you could still do that at Frontier. I believe that's 18 months after completion of your master's, but those things are done in order rather than at the same time. And each term is 11 weeks with 2-week breaks. Great question, Catherine. I will respond to that in just a moment. And you can see here the timelines for completion. So Catherine is asking, can you do women's health and FNP at the same time? Most people are asking, can you do women's health and midwifery at the same time? All valid questions. And I think that the right answer to those things is yes. That's not the answer and it's not because of Frontier, it's because state boards of nursing in the last few years have moved to requiring complete clinical hours in each independent track. So even in areas that have a tremendous amount of overlap, such as midwifery and women's health, or such as family nurse practitioner with like a women's health concentration specialty, even though there's so much redundancy there, individual state boards of nursing are requiring an entirely separate program to grant licensure. And so our upstream responsibility is to, for the money that you're paying, give you a degree that will lead you to the license that you want. So right now we are not able to offer any dual degrees, which is a bummer, especially with midwifery and women's health, because it's like, I'll guess on a percentage, 80% overlap. To Alicia's question, or Alicia, I'm not sure how you pronounce it. Apologies if I didn't get it right. No, you don't have to repeat a course. So that's the good part. When you come back for a postgraduate certificate, that is a shorter experience than your first master's. And it depends how much overlap there is. So all advanced practice nursing programs require what we call the 3 Ps, which is pathophysiology, psychopharmacology, and physical assessment. And so those will typically carry over from university to university or program to program, assuming they were the same number of credit hours. And then the management courses that overlap, you would not have to repeat. So say, for example, you did midwifery first and you took, a GYN course or an antepartum course. If the content was similar enough to the same course in the women's health program, you would not have to repeat it. Some courses, the content is organized differently, meaning that, like, say, for example, this is just an example, this isn't how it is, but say in family, women's health or GYN, antepartum, and newborn was all one course. And then you come back to be a women's health NP, but there's a much more robust GYN course rather than a GYN course that's tossed into the same 3 credit hours with newborn and antepartum. You might have to still take that GYN course because you didn't receive the sort of all of the objectives that you would at another time. But we're reasonable people and we understand that lots and lots of folks, including, I would say, probably a good majority of our faculty have multiple specialties. So it's very, very common to do the PGC, the postgraduate certificate. Next slide, please. Okay, so what are the criteria for admissions? And please, if somebody else is on this call and you're like, I'd rather do this slide, I'm happy to sit back and drink my coffee. I'm just going along until I need you to jump in. So you do have to be an RN with a current active license. This is kind of wild, but you can have a bachelor's in any field. So you don't have to have a BSN. This is actually similar to what I did. I had my undergraduate was in gender studies. And then I had an RN and then I progressed to an advanced practice nursing program. So you could have a bachelor's in something other than nursing, but you do need to have a bachelor's because this is a master's degree program and a bachelor's is required for entry. For most of you, that's going to mean that you have a BSN, but I'm just spelling that out. You need to have a 3.0 or above GPA from your highest nursing degree earned. So say you had a associate's degree and you had a 3.7, and then in your bachelor's you had a 3.9 or whatever. The bachelor's would be the highest nursing degree earned. You need to be in good academic standing from your prior coursework. 1 year of RN experience. That year does not have to be in the specialty area you're applying for. It's super helpful if it is. Preceptors really like to see, potential preceptors really like to see that, but that's not a criteria for admission. And then we have this quirky thing about New York State that we don't need to worry about unless you're in New York State. You can talk to the admissions folks about it. You can live in New York. You just can't go to clinical in New York if you're not one of these special spots. And this is, again, a New York issue, not a Frontier issue, because we serve all 50 states and DC. Okay, Catherine, I'm in my final year of FNP, want to specialize in women's health. Once I finish, I can apply for the women's health certificate. I think what you're asking, Catherine, but feel free to unmute and clarify if I'm wrong. What you would be doing is applying for the PGC program here. I apologize, I don't know if you're doing FNP at Frontier or elsewhere, but if you already have a master's as an FNP, you'd be applying for the postgraduate certificate program.
Okay, thank you. I'm doing my FNP at the University of Orono in Maine.
Mhm.
Yeah,
Okay.
so I really love the women's health component that I already completed, and I was just looking to specialize so that I can give, I guess, more in-depth care to women's
Right.
health. Yeah.
And I think that if that's the career that you want, you'll find that really helpful. There are a lot of FNPs who take a job in like a women's health role and struggle because of their limited education. Like I've precepted lots of FNPs that, it's an 80-hour rotation. Whereas, in the women's health track, you get 750 hours of immersion with a lot of nuance. For clarification, it is a certificate, but it's another whole, I'm not sure I'm even going to find the language, so somebody else jump in if you want to help me, but it is completion of another whole track. It's not like getting a certificate of like, I went to a 3-day training and now I can do limited ultrasound kind of certificate. Like you're gonna pursue another entire degree. It's not like another master's, but you'll be eligible for certification as a women's health NP. So it's not like you'll be an FNP with a women's health certificate. If you were to do both, you would sign your name like FNP, WHNP. And that's probably exactly what you're saying, but I know there's like a lot of nuance. And for some people, this is their first time thinking about advanced practice nursing education. So I just wanted to clarify that.
Thank you. Yeah, because it would be like some other providers can refer their women's health patients to me where I'm specializing in that area.
Exactly. Yeah, it's super confusing though, because like you could specialize in menopause. There's no like other degree for that. You know what I mean? But this is specifically, to add an entire other credential to your name. Yeah. Next slide, please. Okay, so admissions criteria for the PGC is, again, you have to have a master's or higher in nursing in a advanced practice nursing specialty. So it can't be like as a nurse educator or a nurse leader or something like that. The PGC program is really only relevant for folks who are already an advanced practice nurse. If you have another one of those degrees, you would be eligible to enter our MSN program because that's a different role. An advanced practice nurse is a different role than those other nursing masters. Isn't nursing wild? I know you already all know that, but it's like literally how many layers? So hit me with the questions as you have them. Next slide, please. And you can see this. This is just a list of all the specialties in advanced practice nursing. Next slide. I see your question, Kimberly. I'll answer that in just a moment. So this slide is just saying that we're very mission and vision driven as an organization, and that when you're a student here at Frontier, you will be surrounded by folks on that same mission and vision, including our faculty and staff, which is to provide exceptional care to the public. So, Christina, I love this question. Okay, I'm going to get Kimberly's first, but Christina's question hits at my adoration of nuance in our field. So, how many students are accepted into each program? I'm not sure that putting a number on that is going to be the best way to respond because our admissions are rolling. And so the numbers are a little bit fluctuating each term depending on how many folks we currently have in the program and how many applications we have. If somebody else wants to commit to a number, you can, but I don't want to be out of my lane and say a number, even though I have some inside my head. So I will defer that maybe to Tamika momentarily. And then to Christina's question, I love this question. Thank you for observing. Certified Nurse Midwife does not have an NP in it. Is CNM still considered an NP? This is another wild nursing thing. So all of those roles that I just mentioned are advanced practice nursing roles. But advanced practice nursing and nurse practitioner, while they both have N's and P's in them, are not identical. So advanced practice nurses are nurse practitioners, nurse anesthetists, nurse midwives, and clinical nurse specialists. So only 1 out of 4 of those advanced practice roles are nurse practitioners. So nurse midwives, you are correct, are not nurse practitioners, but are advanced practice nurses. Does the general public know that? No. And most employers don't know that. They don't even know that a PA is different. So in some ways, this is like really not of interest to most folks, but excellent question. And if there's a why behind that question, hit me with it. Tamika, do you want to say numbers or should we just tell people apply?
Well, unfortunately, they don't give us numbers for the same
Okay.
reason that you just gave, with them being fluctuating and changing. So they don't give us numbers, unfortunately.
Sorry, it took me a second to unmute. What I will say is it's not like you shouldn't try. And when you have an individual communication with an enrollment coordinator, they can let you know the best time to target your application. This is, as you can just see from our numbers, this is not a program that takes 5 students a year. So we offer DNP, but in the midwifery or in the masters, we have women's health, midwifery, psych, mental health, and FNP. So we're looking at enrolling, hundreds of students every term overall. What other questions do folks have? Do we have an acceptance rate you can share? I actually don't, because again, I'm not sure how it's calculated since we admit on a rolling basis too. It's not like we have 10 spots and 20 applicants every year. There's so many pieces. Kelly is saying, is it possible to start the program and then take a break and then jump back in? Yeah, great question, Kelly. And it's very, very common to have your own babies in the same decade that you go to graduate school. That is like kind of standard for most folks. So, yes, that's possible. Right now, students are allowed to take 2 academic hiatuses, each one being a full term. So that's an 11-week term with 2 weeks on either end of it. So that's 15 weeks. You can take 2 of those in, I think, a 12-month period. It's not a calendar year. So there's some calculation about how you can take them. And so, yeah, that's what you're describing is a common situation. And I believe tuition is consistent there. I don't think there's in-state tuition in Kentucky. There might be some kind of benefit. Does anyone know? Is there any sort of benefit if you're a resident of Kentucky? I mean, we're a private school, but I thought there might be some kind of other scholarship that's available or something like that. But the tuition is the tuition. You don't even have to live in the US to get the tuition. You have to live in the US for clinical, but you can live anywhere you have an internet connection for the didactic part of the program. I can't remember, Ava, even though I do this all the time. Are there any slides after this? Okay, deadlines. Okay, great. Let's look at that while I answer the next 2 questions, and then we can see if somebody wants to answer these other questions, if there are any specific to this slide. So how many terms are in the program? Thank you, Tamika, for putting that in because it varies from full-time and part-time. So I was going to try to rack my brain. And yeah, so full-time and part-time vary. And then is it possible to move states? Absolutely. You can live wherever you want. The main thing is, this go back to Jennifer's question. The main thing is when you're putting together your plan for clinical, which needs to be done, I mean, at least 6 months before you would need to go to clinical, especially for midwifery students, because you usually need a hospital contract. It's really about projecting where am I going to live when I'm in clinical. And so, again, a lot of times we have students who are maybe in the military, they're not sure where they're going to be next. I mean, we'll just figure it out. We figure it out with everybody, but that's the biggest piece is knowing where you're going to live when you're in clinical. Catherine, I don't think that's a problem. I think you can live anywhere. I don't think you even have to have a US address when you enroll, but somebody jump in if I'm wrong, like Tamika. I'm Tamika has to solve all my problems tonight. They don't have to
You
be
know,
living in the US to enroll, right?
living in the US to enroll, no, but they
Yeah.
would still need to, of course, complete the clinicals in the US and
Right.
have that
Yeah, yeah.
active US license. Yeah.
Yep, exactly. Yep. What makes applicants stand out for acceptance? No, it's I can't think of the word right now because it's the end of the day. Holistic admissions. That's the word I'm looking for. So we look at the whole admissions package, and GPA is one part of that. Can you go slower than part-time? So, no. The only way you could go slower than part-time would be if you took your 2 academic hiatuses. The reason I don't recommend that is because it's very difficult to retain the information when you're moving at a slower pace. The other reason is that there's a maximum amount of time you can take to complete the program because our friends at the state boards of nursing often require that your pharmacology course and some of the other courses you'll take in your first term are not more than 5 years old at the time that you apply for licensure. So our job is to set you up for success. So you can't really do like a, I'm just going to take one class at a time kind of situation. But you could certainly talk to the enrollment officers about what a part-time program of study looks like in detail and where you might fit your academic hiatuses in there if that's what would work best for you. Jessica's question is how many clinical days are required per week? So the last 3 terms that you're in the program, um, yes, I'm going to answer Jessica and Kelly at the same time. So the last 3 terms are clinical terms. So those are included in the 9 to 12 terms to complete the program. The last 3 terms you're in clinical. And there is a slight variation in the minimum number of hours you have to be in clinical per term. The average is 24 hours a week minimum. One of the terms it's 20, one it's 24, and one it's 28. And the only reason there's that variation is because it has to align with the credit hours for each of those terms. But big picture for you to just think about your life, those last 3 terms, you need to be in clinical a minimum of 24 hours a week. You certainly can be there 40 hours a week if that's okay with your preceptor and it works for your life. And I think that's a great idea, but we don't require it. And so like in midwifery, you can't work 24 hours straight, but you could work close to 24 hours straight. So in midwifery, a lot of people will do one like 20-hour call shift and one like 8-hour clinical day. And that would be enough. But you have to think about if you're taking a 20-hour call shift, you got to sleep at some point. So it's not like you get like a free day because somewhere in there you have to sleep. And then the other thing to think about is how busy the practice is. Again, if you're looking at a midwifery program, yeah, and I see the questions about work. Thank you. I'll get to those in just a moment. If you're looking at a midwifery program, you've also got to look at how busy the practices are where you're hoping to be a student because, if they have 2 births a week, you can be on call for a zillion 24-hour shifts. It's going to take you a really long time to get your birth. So it's definitely about kind of putting that puzzle together. Like how much availability do I have to get the skills that I need at this particular setting? And yes, absolutely students work. I would say the majority of our students do work full time, certainly during the didactic portion of the program. And many students work full time during the clinical portion of our program. If you're able, I don't even know if this exists anymore in the labor and birth nursing world, but if you're able to do like weekend option and count that as full time where you work like a 12 on Saturday and a 12 on Sunday, I mean, good for you. I don't know that exists that much anymore. So getting into clinical, it can be very difficult to work full time. The other question is just what other responsibilities do you have? If you do a lot of caregiving, and have other responsibilities, that's going to be more challenging, than if don't have anything else to focus on. Um, Danielle, that question is a bit nuanced. If it's your wedding, congratulations in advance. you can take a break during any term for a handful of days. So just a couple of days probably doesn't need to change your whole program of study. Are there any questions specific to this slide that's up? I see Tamika's answering some questions in the chat, but if not, we could probably take the slide deck down and then see each other a little bit better. Oh, look, all the things I was saying. And you think I'd never seen this slide deck before. I've seen it like a million times. I just started answering all the questions. Okay, so let me just hit on these if I didn't already. Each program, whether it's MSN or PGC, has a minimum of 750 clinical hours. And the midwifery thing, we're good with that. Next slide, please. This is our lovely campus. It is so lovely. It's so lovely that I go there more often than I have to. It's nice because it's driving distance from my home. I mean, it's 3 hours. It's not like down the street, but it's a really lovely place to be. And like I had said before, faculty, staff are mostly living in the area around campus. Faculty live all over the country. So, and we need that social scaffolding as well to continue to do the work that we do and engage in our culture of caring. So we all really love when we have the opportunity to go to campus, and we rotate that opportunity to be on campus with you. And you're probably curious about the 2 times you have to come to campus. So one of the times is the term prior to your enrollment. So say you would start summer term, sometime in spring term, you would come to campus. And then the other time is the very beginning of the term, you start clinical, you come back to campus. The first trip is just 2 days, maybe 2.5. The second trip is Monday through Friday. And so a group of faculty and staff are on campus with students almost every week of the term. And we've got walking trails and a big dining hall, and we live together in these lodges, and it's a whole thing that we enjoy very much and we think is an important part of the experience of being a student at Frontier. Great question, Catherine. Are we good to take down the slide deck and I'll answer that? Okay, good. We'll get to that. Thank you. Okay, and Tamika, thank you for answering those questions about credit hours and cost. This is a great question about the DNP. So the other thing I wish was that there was a way that you could do the DNP as like a PGC at the same time. Ava, can we just take down the whole slide deck so I can see everybody? I don't know if you can. If not, don't worry about it if technology is a hang up. I know that's why I wanted you to advance it, because when I'm sharing in that view, I'm like afraid I'm going to close the Zoom meeting if I take it down. Good job. Okay, you did it. Thank you. So I wish there was a way we can, and Kanisha, great question. I'll get to that in just a moment. I wish there was a way to do the DNP and a PGC at the same time. The universe just really isn't set up like that. We've explored if that's something we could do just at Frontier. Because the DNP has different accreditation requirements and different outcome requirements, there isn't a way to like make it an additional clinical role. So the DNP is a leadership role in quality improvement and translational research, which means that unlike a PhD where you're like, I'm going to find out what population, has the most chlamydia or something, or what drug works the best to treat chlamydia in a certain population. Instead, the DNP role is asking, okay, we know that this is the best drug to treat chlamydia. Why is it that at some sites, that isn't the drug that's being utilized? Is it because people don't know? Is it because it's too expensive? Is it because it's not available? Like that is just one little tiny example. But that role is about what is the gap between what we know to be true and what's actually happening in practice. And so all of the classes and all of they're called clinical hours, but the classes and the clinical hours are all about leadership and implementation of a project to try to close that gap. There isn't an opportunity there to gain an additional clinical specialty. So in the BSN to DNP programs, you do both. You get a clinical specialty and you get the leadership. But for a postmaster's DNP, like what we offer, the individual has already gained the clinical specialty, and then they add on the 18 months of leadership and quality improvement. Does that sort of make sense?
Yes, thank you.
Oh my gosh, trust me, I totally understand these questions. It's like, what in the world? It's very confusing. Yeah, and so to expand on Tamika's response to Kanisha, I hope I'm saying your name right, Kanisha's question. All students are online, so it's not like there's some students that are not online. All students are online and no need to apologize. It's a shared process of identifying your clinical plan. So, our philosophy is that students are experts in their home community. You know, I don't live everywhere that you live. So you're the first expert in your home community. Like, who do I know around here? How did I even decide I want to be a midwife? Am I aware that there's midwives in my community? And at the same time, from the moment you're on campus at Frontier Bound, you have a clinical advisor who will help you see our platform of sites that already have partnerships with Frontier. And you will have both staff and faculty who help you put together that clinical plan. So it's a shared experience. You could come to us and say, I have a whole plan. This is what I'm going to do. And we will still say, let's talk it through and make sure it meets all your requirements. You could come to us and say, I have absolutely no idea what I'm going to do. I just moved back from, somewhere across the country and I've never even worked in labor and delivery. I'm completely lost and we'll help you from there or somewhere in the middle. But we definitely don't say, okay, Danielle, you're going to this place in South Dakota and you have to be there on this date, the end. We work with you in collaboration to put together a plan that makes sense for you and meets the program's requirements. Whew, I talk a lot and that was all in my head. I don't even use notes. Does it hurt my application to not be an L&D? Not at all. So Kimberly, great question. It does not hurt your application. And I hate to say this because I actually think that, and yeah, I'll talk to the preceptor thing in just a minute. I think it brings such a richness to the profession when we don't all come from labor and delivery. I was never even a nurse. I had a bachelor's degree. I told you a little bit about my journey, but I went to a program where I had a bachelor's degree in something else, and I did an accelerated program where I started my master's coursework and became a nurse at the same time. So I've never even worked one day as an RN. I mean, I have an RN, but I went straight to becoming an advanced practice nurse. So I think there is a lot of richness that can come to our profession from folks who have training in other disciplines. But what I want to say, to be really honest and fair, is that our profession has changed a lot in the last probably 12 to 15 years that I've been in midwifery academia. And midwifery care has become much more acute. We take care of a lot of folks who are really, really sick, not just healthy physiologic pregnancy. And so those sites and settings that are really busy, like tertiary care centers, often only want to take students with labor and birth experience. So there are lots of sites all over the country that don't have that requirement, and we absolutely do not have that requirement for admission. But I want to be honest that it does help to have labor and delivery experience when identifying your clinical site. And it hurts my heart to say that because I think that um, it dilutes the richness of our profession. But I also want to be honest and help you have the best chance at finding a clinical site. So what some students will do is, get admitted to the program and then ask to be moved to labor and birth if they can, so that by the time they enter clinical, they have had some of that experience. Kalanda, hope I'm saying your name right. Preceptors have to be advanced practice nurses. You can have a small portion of your time with a physician, but the advanced practice nursing role is different than the skills that you will learn. So you can learn skills from all kinds of people, but the role in terms of how it involves consultation, collaboration, and referral at the advanced practice nursing role is pretty specific. So you can have about 20% of your clinical experience with a physician preceptor. Um, in the midwifery program, you need to have a minimum of 50% of your total experience with a nurse midwife preceptor, but you can also have FNPs and WHNPs, so family nurse practitioners, women's health nurse practitioners as preceptors. Okay, with the MSN degree, are the PGC for okay, and would these programs be more of an accelerated, we're already completed courses? Yeah, great question. For somebody who wants to do midwifery and women's health, um, at this moment in time, this could change in a year or whatever, but at this moment in time, it is definitely more efficient to do midwifery first because midwifery carries a broader or covers a broader expansive knowledge. And so then when you come back to the Women's Health NP, there's very few things that need to be repeated. Whereas doing the Women's Health NP first, then there's a lot of new content for midwifery. In your case, though, Catherine, with being about to finish the FNP, what's tough is if you did the PGC in women's health first, then you could start practicing as a women's health NP. So certainly happy to have a separate conversation with you if you want. My email is literally just eva.fried@frontier.edu. It's technically eva.fried01, but I have it forwarded from eva.fried, so you don't have to know that. But if I don't get back to you, ask somebody else because maybe it didn't get to me, but that's been working. Yeah, so Christina, this is a great question about counting hours with a licensed midwife or a certified professional midwife. Unfortunately, that's not permitted. And again, that goes back to the role issue. It's not that licensed midwives and certified professional midwives are not experts in physiologic birth. They are. But from a role perspective, our legal responsibilities and our ability to prescribe and collaborate with physicians and have hospital privileges are very different in the two roles. So it's not at all to diminish that other role, but you do need to have a nurse midwife preceptor. What other questions? Well, I really appreciate everyone's interest. Okay, since I definitely talked the whole entire time, anybody else on staff wish that you could say more, not in the chat before we sign off? No, they're all like, thank goodness you talked, so I didn't have to. Okay, cool. I appreciate the whole team. Yeah, if there's no other questions, we'll go ahead and sign off. I think you'll all get a recording of this if you need it to keep you company at some later date. And we are all happy to hear from you. Post MSN, how many months would the Women's Health Certificate be? So if you did it post FNP, I forget we had that slide up about how many months it was. If you did it post midwifery, it would be shorter. I'm gonna say, I know you at least need the 3 clinical terms. I think at this moment, things can always change, but I think at this moment, post midwifery, there's only 1 additional didactic term. Post FNP, I don't know how many terms, but if you looked at the recording, Catherine, you would see the slide that said exactly for PGC. The
I
recording
want
will
to
go
say
out
it
to
might
everybody who
be,
registered. Sorry, Quincy, go ahead.
no, you're sorry. I want to say it's 18 months, but Tamika, do you know for the PGC? You're muted.
Sorry, it is 18 months.
Okay.
Yep.
And then the recording, Bobby, if you registered for the Q&A, and received an email reminding you about the Q&A today, we will send a recording to that address. And if not, you can chat myself or Ava, your email, and we will send it to you.
Okay, I'm glad you found it helpful. We can't wait to hear from more of you. We'll look out for your names to pop up again. Thanks for spending an hour with us.